Ladies and gentlemen, thank you for standing by. Welcome to the CDC Perinatal Quality Collaboratives webinar series. During the presentation, all participants will be in a listen-only mode. Afterwards, we will conduct a question and answer session. At this time, if you have a question, please press star followed by the 1 on your telephone. You may also enter questions at any time throughout the webinar by using the chat feature located in the lower left corner of your screen. If you need to reach an operator at any time, please press star 0. As a reminder, this conference is being recorded Thursday, July 30th, 2015. I would now like to turn the conference over to Dr. Henderson.
Good afternoon. My name is Jaquiba Henderson, and I lead the activities in support of state-based perinatal quality collaboratives in the Division of Reproductive Health at CDC. And I'd like to welcome you to the next series of webinars we're sponsoring on perinatal quality collaboratives. Today's webcast will present a discussion of quality improvement initiatives addressing engagement of patients and families to enhance the collaboration to improve perinatal outcomes. This is part 2 in a 3-part series on patient and family engagement, and will focus on training and supporting providers for successful patient and family engagement. At the end of the presentation, you'll have the opportunity to ask questions and participate in discussion with the presenter. You may also submit questions via the chat function. A recording of this webinar will be archived on our webpage at www.cdc.gov/reproductive-health/maternal infant health/PQC. Handouts were made available with your reminder email after registration for the webinar, and will also be made available again to registrants in a follow-up communication after the presentation. Our speaker today is Tara Bristol. Tara Bristol currently serves as the Director of Patient and Family Partnerships for the Perinatal Quality Collaborative of North Carolina. She has over 8 years of experience as a patient family advisor, serving as a partner in quality initiatives, and over 6 years experience coaching statewide and national hospital teams on engaging patients and families in their quality improvement efforts. This includes faculty roles with the Institute for Healthcare Improvement, the National Institute for Children's Healthcare Quality, the North Carolina Hospital Association, Patient and Family Centered Care Partners, and others. We are very pleased that she will be sharing such an important topic with us today. I will now turn the presentation over to Tara.
Thank you, Dr. Henderson. It is, again, just an honor and privilege to be joining you all today and for our second series on patient and family engagement. For those who maybe weren't able to join us in May, during that session, we really highlighted the landscape of patient and family engagement nationally and went through some of the frameworks that could potentially be used for engagement. And as Dr. Henderson said, that webinar along with this one are all archived on the CDC PQC website. So I invite you to get a refresher or check it out if you weren't able to be on the first one, and please do share these resources with anyone that you think might find this useful. But during our time together today, what we hope to do is build on what we discussed in terms of engaging people in improvement during May, and really focus on provider engagement and how we can prepare them and support them to be partners in this work. So on the next slide here, I think this is, and I shared this quote because I think it is just so powerful in the last webinar. It says, "We are professionals with a license to practice. We don't need families to let us know if we do it wrong." This is why this work is so hard. This is a very new way of practicing, and it can be very, very intimidating to nurses and other providers and staff who are working with families and are told now we need to rethink how we're interacting so that we have a collaborative model with patients and families. On the next slide, it highlights a quote that came out of the Institute of Medicine publication in 2013 about partnering with patients. And and really states, patient engagement is a skill, not a trait. So not only are we asking you to change your culture, you haven't been equipped with all the skills you need to do it, and it's not something that we are all born with. And so hopefully in the next hour or more together, you'll be able to take away some tips and tools that will be able to help you do this at home. So we'll start on the next slide with some suggested curriculum for provider education. And so maybe you've made the decision, we are going to engage patients and families, but before we do that, how do we really give some anticipatory guidance to providers and other staff or organizational folks to do this effectively? And these are some common curriculum best practices that are used. The first being the patient's hospital experience, or the importance of patient and family perspective. And that can come as part of a patient-family panel, perhaps, or other ways where patients and families display their unique expertise. And I found truly that if there's going to be one tipping point, if you've got people who think, you know what, I really don't know if I buy this. I don't know that I want a parent on the quality improvement team with me. This can be your tipping point, allowing them to hear from patients and family members their perspective, and seeing that there are folks out there who want to be constructive collaborators with us. The second suggestion for curriculum is an introduction to patient and family-centered care and patient and family engagement. We toss these terms around quite a bit, as well as patient experience for those working in hospitals, and often tied to our HCAHPS, Press-Ganey, or other patient family satisfaction scores. But oftentimes we don't really have a common understanding of what this means. And so providing some definitions and creating common language can be a good way to move forward as an organization in your engagement efforts. Another thing to think about sharing as either part of one of the other items or as a standalone are the benefits and outcomes of engaging patients and families as partners. This still, despite all the progress we've made and incredible organizations like CDC and IOM and AHRQ and those supporting this, a lot of people think of this as the fluff stuff, that this is just a nice thing to do, when in actuality it's really improving our clinical outcomes, of course, satisfaction scores, not just for patients and families though, but for providers and staff as well. So sharing some of that can be a carrot that may be what motivates others in your institution to take on this work. Also talking about the roles for patients and family members. A lot of times, people are on board. Yes, we know they're an important part of the work we're going to do, and I can maybe think of one or two patients to recruit, but what do we do with them? Where do we start? So helping your teams understand what the potential roles of patients and families will be. Also, characteristics of engaged patients and family members. So it's really important to choose collaborative partners who are solution-focused, to be the ones sitting at the table with you. So helping staff and providers understand what characteristics do these folks have, and providing education on that. And finally, how to effectively work with patients and family members, because it's not enough just to bring them on the team. It's really important to provide them with touch points and orientation and continued support. We won't be talking about any of these really in much detail today, but I will put a plug in for our next webinar, which will be surrounding recruiting, orienting, and engaging patient and family members. I do want to provide you with some resources too, though. So on the next slide, for those of you who are out there ready to get this started, this is one of my most go-to places for resources. So AHRQ has a guide to patient and family engagement that has really turnkey presentations, handouts, application forms for patient and family members, but in PDF, or not in PDF form, also in PDF form, but PowerPoint form, Word form, where you can take and place your organization or hospital logo on it and really tailor it to be what you need locally to do this work. There is a whole PowerPoint that can be used for providers that touches on kind of all the things that we spoke about in the previous slide about, what are the benefits to patient and family engagement, what are the roles for advisors, what can you do as staff to support this. And so I encourage you, the link is provided, to go and explore the tools provided by AHRQ and take them and start using them right away. There really is no need for you to go out and recreate the wheel, because I think that's what makes some of this so overwhelming at times, is that you're being asked to work in this kind of new content area and create materials. So please check out those resources. The next slide has another place where you can go for resources. So on this next slide, coming up, you will see the Institute for Patient and Family Centered Care, IPSCC for short, has some really wonderful free resources available. In particular, in their tools and checklists, I wanted to highlight one of the items that may be very useful to you as you're thinking about how do we support and train providers in doing this work. This happens to be kind of a checklist of what are the characteristics you want to look for, what is the role of a staff liaison to patient and family advisory councils and other collaborative endeavors. It says councils, but really the staff liaison role is so important, whether you're having parents and family members come in to do a panel of their patient experience, or whether they're joining you on a quality improvement team or doing other things. There are just some core things that we can do as staff and providers to help support these efforts. And so this is a great tool. There are many others on the Institute for Patient Family Centered Care website. Again, the link is provided, and I encourage you to go and look and find what really is going to be meaningful for you in this work. On the next slide, I want to share a little bit different resource for you. So you may be thinking, I'm a nurse manager, or I'm a social worker. I don't have time within my roles and responsibilities to be doing these trainings and coming up with content. Isn't there someone I can just bring in to do this for me? Patient and Family Centered Care Partners out of California works with hospital systems, organizations, community organizations across the country to prepare not only patient and family advisors, but providers to establish partnerships on teams. And so they have a completing the team training. You can see some of the components of the training there listed, but they are another resource for you to call in and say, you know what, we want to do training for X, Y, and Z providers, and can you come in and do that? So that's another resource to think about as you move into this work. Now that we've talked just briefly and highlighted some resources that may be meaningful for all of you, the next slide is going to transition us into patient and family members as faculty members. So what does that mean? The next slide has a little definition about what are faculty programs. So family faculty programs involve patients and families as educators in a wide variety of formats, including grand rounds, small workshops, classroom settings, practicums, and community programs and home visits. So that's what we're talking about when we discuss family faculty programs. On the next slide, we are going to talk about what are the characteristics to look for in patient, family, faculty members. So this is the point where you've decided, you know what, we need to do some education to support our providers. What will that look like? Let's bring some patient and family members to do this. So we want folks with excellent communication skills. So we're not talking about people who have, a bachelor's degree or a master's degree. That's not what's needed. It's really someone who's able to communicate effectively. And a part of that being the ability to share their personal experience in a way that others may learn from them. So not folks who are going to go up and give you a laundry list of what went wrong in their personal healthcare experience, but we want individuals who can tell you what went well, and also what did go wrong and how could it have been done better. So that's making the personal story a very meaningful part of education. We also want individuals who are able to see the big picture beyond one's personal experience. A lot of times when we're starting out in patient and family engagement work, we're bringing in one patient or family member to start this off because as you can imagine, it's very overwhelming to think, gosh, I need a patient that represents one that represents each kind of population group that we care for. So we need 10 people, do we need 15 people? Start out with one, but it needs to be one who can see the big picture. So it's not all about what happened to me personally. My personal experience is having a 27-weeker who spent 83 days in the NICU. That's my personal experience. I can see beyond that to the bigger picture of the NICU experience and what's that like. But then you want these folks who then can move even beyond that further. So it's not just about my 27-weeker, not just about being in the NICU, but it's about healthcare as a whole and how can you promote effective communication and transparency. So that's what we mean by people who are able to see the big picture of care. An ability to listen to others. There is nothing that will stop patient and family engagement work dead in its tracks faster than bringing in someone who just wants to talk and isn't able to kind of read the social cues of others and understand when it's time to listen. You want people who are concerned about more than one issue. So, maybe my baby got an infection while in the NICU, and this is something I'm so passionate about that I really want to work collaboratively to make sure the preventable infection never happens. But when you're thinking about people to bring on your teams, unless it's specifically an improvement team that's working on infection, you really want individuals who can think about more than one issue. Also sensitive to the needs of others. And by that we mean not only we want them to be sensitive to the needs of other parents and family members at the table, but also to providers and staff and who have an understanding of what are potential barriers to making things happen. How are decisions made within an organization and how does improvement work happen? So being able to acknowledge and be sensitive to those issues that come up. And I'm going to say it again because it's that important, is we want individuals who have superb listening skills. So on the next slide, you found these wonderful people who embody all of the characteristics that I've described very briefly. What can you do with these individuals in order to support and train providers? Well, first is to think about, and I mentioned how this can be such a tipping point, is to bring people in to share personal stories, whether one-on-one or in a group setting. And I would encourage you as we go through roles for patient and family members to think about what do you already have in place that it could be utilized. Is it a monthly staff meeting? Is it a family-centered care committee? Is it a quality improvement group, an annual meeting of sorts? So really think about, it's not about creating new venues all the time for this, but what venues do you have in existence where you could bring a family member or family members, multiple family members in to share their personal perspective. Also, having patient and family members participate in small group discussions to train professionals. This was something the healthcare system that I worked in, we wanted to do some bereavement work and really create a more supportive program for parents who were experiencing a loss within the inpatient setting. And so we brought in families who had experienced loss within our unit to share and talk with our quality improvement group about, what was beneficial, what was missing, and what are some ideas about how we could better support families. Role-playing interactions with families. We think, simulations are used to train staff on how to respond to various clinical events and that. But what about having patients and families come in and play that role? Because when you think about it and you're in the midst of it, it's not a silent patient or silent family member who's sitting in there with you. Often a big part of that is meeting the needs of patients and families during these critical events. So bringing them in to help with that, and whether it's in simulation or just maybe practicing difficult conversations, it becomes much more authentic to try this role-playing with families. And of course, again, I'll highlight these need to be family members who are well prepared to be a part of this and have the characteristics we talked about, because this needs to be a safe place for staff and providers to engage with families in this way. The next slide, we've got some more opportunities for patient, family, and faculty. Presenting at orientation meetings, grand rounds, and other continuing education programs. I'm going to give you an example in just a little bit of a healthcare system that does this. But again, these are the things that you already have in place. And so is it that you want to bring family members who have had a specific clinical experience come and share? But this can be just a really great way for those providers who are on the fence about doing this to build trust and familiarize themselves with family members so that then you can move forward in partnership work. Interacting with health professionals as patient and family advocates. So some of you in your organizations may have positions like that, whether it's called an advocate or a navigator or whatever term your organization uses. But just having those folks there is an education in patient and family engagement. I will point out that the role of an advocate is different than the role of a patient family advisor or partner. And so there may be less of an emphasis on solution-focused, constructive collaboration in some advocacy roles. So that's something you just want to keep in mind as you're thinking about how to provide education through connection with advocates. On the next slide, we've got some even more ideas for how to use patient family faculty. co-instructing courses. So you may think, oh gosh, that sounds like a lot of work. But this could be for part of a course. It could be for the entire course. There is here in North Carolina where I am located, the School of Public Health has a class on children with special health care needs. And so a huge part of the learning for that course is that they bring in parents who are paid to be co-instructors as part of that course. So I encourage you to think really creatively, and maybe it's not a full course in terms of you think of a semester-long thing, but maybe it's some sort of continuing education opportunity that you have surrounding, something specific, gastroschisis. So bringing in families with lived experience and having them co-instruct in those courses. Having patients and families consult in curriculum development and review. So this can be, maybe you've created a course and you want them to help look at what you've developed and figure out what's missing or what could be included. It may be, I know that at our hospital we had a committee that met monthly to go over any patient education materials so that it could be really consistent throughout the institution and that there wasn't a lot of recreating the wheel for things. So include patients and families as part of that. It would probably amaze you about how much time and effort you would save by including patients from the outset, because they're really great at saying, I have no idea what you mean by that, or, that's important, but when I went home with my baby who had this is really where we needed more information is in this area. Can we include this in the curriculum? So including them as part of that. Also participating in collaborative projects. I know many of you on the phone are part of perinatal quality collaboratives, and whether you're working on neonatal abstinence or you're working on breastfeeding or whatever content area, bringing patients and families in as partners in that work. So many of us are working on preeclampsia right now, and there are some excellent resources that are already out there from the Preeclampsia Foundation, but bringing local patients and family members in who can look at some of the things who sit on the team with you and are reviewing the same materials you are, who can say, you know what, let's localize this even more to make it more meaningful for the people that we're caring for. So that would be an example of participation on collaborative projects. And then finally on the next slide, a couple more ideas for how you might utilize patient, family, faculty. One is to pair with students to share patient and family experiences over time. A lot of times there will be maybe there's a residency clinic in pediatrics, and so patient and family members are a part of caring for incoming families in the clinic can be a way to do it. But really starting out, let's start the foundation of patient and family engagement and the importance of it, and start it with our medical students and our residents and our fellows, and find opportunities where they can learn from one another. And hosting students on home visits. There are organizations where this is what they do. They really create training programs where a student or resident may follow a family, to appointments and to come home and see what it's like. What is the medicine regimen? What does that look like for you as a family if you've got to make sure that this child or adult gets this medication 3 times during the day? How do you ensure that happens? And so it can be very enlightening to think about what it looks like at home. I know that we can get so frustrated when maybe families aren't doing exactly what's been prescribed or things like that. It can be getting home with them and realizing, wow, they don't even have the money to pay for the electric bill on a regular basis. No wonder why they aren't filling their prescriptions. So it can be very enlightening and seeing people in their home environment. So hopefully that has been lots of ideas for how you might use family faculty in your training and support. So the next slide, just some tips for developing and maintaining these programs. The earlier you can get patients and family members to be part of the planning process, the better. It can save so much rework. I know I hear a lot of times, well, we're not ready. We don't have all of our ducks in a row. We have to get our team together before we can bring a patient or family member on. But really it's just about saying to the patient and family member, we know you are the most important part of this team, so we want you to come on now. We're still figuring some things out, and I hope you'll be patient with us as we do this, but you are so important. We can't start this work without you. So just being honest about what potential barriers are, but getting them involved as early as possible. Identify goals and objectives for the program. I was just at a infant mortality reduction meeting the last couple days through COIN, Collaborative Innovation and Improvement Network. And we were talking about patient and family engagement and the work involved with it, and someone made the comment, we weren't getting anything done until we came up with a plan and structure. So this is as true for faculty programs as for anything else, but just making sure you've identified the goals and objectives. Conduct outreach efforts to continuously recruit patient and family faculty members. Again, creating a structure and a process for this, because, what can happen is if you're using the same 3 to 5 amazing people that you've recruited every single time, they can get burnt out, and the time demands can be just too much for them. And also providers in that may think, gosh, I really would love to hear from someone beyond the same 3 people every time. And also the relevance of their experience changes over time. My son's NICU experience was 10 years ago. NICU looks very different now than it did 10 years ago when he was in it. And so really thinking about that as you're engaging people and making sure you're always bringing in fresh perspectives. Provide orientation to familiarize patient, family, faculty members. And I want to remind you, when I went through some of the tools and resources, Institute for Patient Family Centered Care has some great checklists of what you should do to orient family members before you engage with them. And there's even one tool very specific to if you're having them present or share, kind of the checklist of what you should go over. So making them feel prepared so that they can be confident in what they're doing. More on role-specific training, offering ongoing support for both family, faculty, and the program's trainees. So sometimes hearing from patients and family members can trigger emotional responses or things that were unanticipated. So a lot of times what we'll suggest is, of course, to let folks know that patients and family members will be speaking or will be serving as faculty member, and then having a debrief afterwards. How did that feel? What surprised you? What didn't surprise you? And doing that in a safe environment. Develop strategies for compensation, reimbursement, and acknowledgement for patient and family faculty members. So whether it's, you know what, we're going to pay for your mileage. We're going to give you a free lunch when you come to this meeting, and we're going to pay for your parking. Some places that may have been able to tap into some budgets, they may be able to provide a stipend for family members to cover any child care costs, because really these are volunteers typically who we're working with, and so they're not getting paid while they're off doing this. Some at the meeting I mentioned that I was at earlier this week, I had some parents say, I had to take vacation days to be here and be part of this, whereas staff and providers are getting paid to be there. So whatever you can do in terms of compensation, even though that's not why patients and families typically get into this, is greatly appreciated. And when you can't do that, ensuring that you acknowledge all that they've done, maybe if they've helped review and create some resources, that you're going to acknowledge them on the resource for their effort, or might co-write an article with them and acknowledge them an author. So there are different ways to provide acknowledgement. Anticipate and plan for resistance to change at all levels. A lesson learned. A dear friend of mine is the patient family-centered care director for a health system, and one of the things they do is provide training for all employees. So this wasn't just new employees, it was all employees at their healthcare system. They were doing a session for physician providers, and they had some parents and patients who were giving their perspective and who really presented a lot of the curriculum. And there was a provider who really, stood up and said, I don't believe in this. It's just, and they weren't necessarily prepared that first time for that resistance. And so certainly the parent, patient, faculty members weren't prepared to deal with that. So they learned the hard way, as we all often do the first time around, to really anticipate that resistance and come prepared with how are we going to deal with this? Are we going to, take this offline as opposed to having this discussion in the larger room and context, or, what are our key responses? So anticipating and preparing for that, and developing an ongoing evaluation process. As part of that, I would also encourage you to really be tracking what you're doing. So how many people have you trained in this? And what was their feedback? And because that's one of the things that I tend to find globally in patient-family engagement work, is that people aren't tracking this hard work they're doing. And then, they say, well, we've barely gotten anything done. But when they sit down and really think about even the small things, it adds up to just really big changes for a system. So with that, I want to share an example from the field. So on the next slide, you'll see we're going to talk about Vidant Health, which is a large healthcare system in eastern North Carolina, tertiary care center, which is nationally recognized for their patient and family-centered care work. Just an incredible place. And I wanted to share just a little bit about their new employee orientation program, which they hold weekly. And it's a 2-day training where folks from multiple disciplines come and share little bits of what they're doing. For the patient and family engagement piece of it, it includes patient and family faculty who share stories, who are doing the training, and it's all customized to the roles represented in the audience. So trying to make it as relevant as possible for the folks attending the training. On the next slide, you'll see everything they do as part of the patient and family engagement curriculum is based in real deal curriculum. And so we'll go through this in more detail over the next number of minutes. But some things to note too is as they go through this curriculum, it is very intentionally shared as the last thing on the agenda because it's really about sending new staff off knowing, this is the most vital thing that you are going to do in your new role. This is a pivotal stage in the employee's role in patient and family engagement. And it's presented in a way that individualizes the new employee's role so that they can see that patient engagement is woven into every aspect of our operation. So over the course of the next slides, what we'll do is go through each of these aspects of the real deal, respect and dignity, education and engagement, asking and acknowledging, and listening and learning. So on the next slide, we will start out with respect and dignity. So these are the real, it's one thing to talk about real deal and patient and family engagement philosophically, but this is the type of information that they provide that gives really specific things that need to be done by staff and providers. So I will knock before entering, smile and introduce myself and my role, address patients by their proper names, support the team, value cultural competence, pay attention to details, and value my appearance and the appearance of my organization. And one of the things they stress, most of us have heard the golden rule, which is, treat others as you want to be treated. Well, Biden goes by the platinum rule, which is treat others as they would like to be treated. And so it's really, putting yourself into the shoes of our patients and families and what can we do to ensure respect and dignity of those individuals. On the next slide, we'll share some examples of education and engagement. I will practice behavior-based expectations, empower patients and families by providing them with timely and accurate information. Commit to return to care initiatives, so using those whiteboards, those communication boards that are in so many rooms nowadays. I'm sure you all can think of a time where that communication board hasn't been updated in 3 shifts. And not just that, but making sure that, if there's a portion on it where patients and families are invited to include their goals or questions or concerns, that they're told that. I know myself as a patient and family member, even if something was at my bedside and appeared to be for me, if I didn't have an explicit invitation to use it, I wouldn't, because it doesn't always feel like your world when you're the patient or family member. It feels like you're visiting someone else's world. Using bedside shift reports, hourly rounding to ensure that there's consistency and connection between the providers and the patients, and supporting family presence. The next slide is going to we'll go through the ask and acknowledge portion of this. So I will ask how the patient would like to be involved in their care and decision making. I think this is so important because when we think about patient and family-centered care, oftentimes we think about, okay, what's the most patient-centered thing we could do? We're going to do that for everyone. Well, patient and family-centered care is about being given choice. And so not every patient wants to be involved in the minutia of every decision being made. And so that's why it's so important to ask how they want to be involved in their care and decision making. Always ask if there are questions or concerns. if there's anything that you can do for the patient, acknowledge that patients come with their own expertise of their bodies and the environment they come from, and build on strengths. I know, a lot of times when we're talking about discharge, it's like, oh, well, they don't have this in place, they don't have this at home, they've got no one to support them. So that all may very well be true, but let's build on the strengths and use those to prepare them for discharge. And appreciate the privilege to serve the patient. You are the most meaningful people in patient and family members' lives during that time of care a lot of times. And so it really can be a privilege to be part of the most amazing and most traumatic events in a patient's life. And then finally, on our next slide, they talk about listening and learning. So I will always seek to improve the care we provide by asking there are things we can do differently. I will consistently ask patients to tell us now any concerns, comments, or compliments that they may have. I'll pause here to just mention a little bit about the Tell Us Now program at Biden. So they have a system. Every patient and family member who comes through their doors is oriented to where there is a phone number, there is a text mechanism, there is an email, every kind of way you can think of reaching out to a person. If patients or families have a concern, they tell us now. So they send it immediately, it's received immediately, and within a certain period of time, anything that comes through, whether it's a concern, comment, or compliment, is addressed by their team. And so they have an on-call system where there's always someone receiving and responding to the Tell Us Now information that comes in from patients and families. And then finally, contributing positively to make things better for patients and families. And I hope that as we've gone through what Biden has put together as the Real Deal curriculum, you've seen some things that you're like, you know what, I want to take this back and utilize in my own work, and whether it's direct patient care or doing improvement work. And keep in mind that this isn't like, you don't have to go tomorrow or this afternoon and say, I'm going to do this every time. Start small, When we say, ask to see if there are things we can do differently. I would challenge you to go tomorrow and just check in with one patient or family member and say, what could we have done differently in your stay here? So start small in trying these things. The culture of Biden Health is just so immersed in this kind of culture of storytelling and patient and family engagement. Before we kind of move on to questions and comments, I want to share a quote that came from their president, Steve Waller. He said, "When we provide kind, compassionate care that focuses on what is best for each and every patient, their families, every visitor and employee, we create stories. We are a story of excellence. It is an amazing story of caring and remarkable people who work together to provide incredible care every day." So with that, I want to go ahead and move us to questions and comments.
Hello. I'd like to ask the operator to open the phone lines for those who are on the phone. And if anyone has questions to submit via chat, you may also do so at this time.
At this time, if you would like to ask a question, press star 1 on your telephone keypad. Again, that's star 1 to ask a question.
And Tara, while we're waiting to see if there are any questions, I actually have a couple of questions. First off, I think this was an excellent presentation. I think you gave some really nice tips to start engaging patients. And I was just curious, you mentioned some great characteristics of patient and family faculty, and I was wondering, how do you find these people? I mean, I understand, you can ask around and ask patients, but logistically, how do you recruit the faculty? Do you go through nursing staff? Do you put out a general advertisement or request? How do you actually find these people?
Yeah, that's a great question. So there are a lot of different mechanisms for recruiting patient and family advisors or faculty members. One of the best ways is really especially when you're just starting out, is to connect with providers who are actually providing, care to these folks, because you get to know people. And say, do you have any memorable patients or family members who you think might be interested in doing this? A lot of great recommendations come that way. Social workers who work within your unit or case managers or other great people. A really interesting thing that method for recruiting, which scares some people, but so Biden, who I just spoke about, who at one time had, I want to say, 300 patient family advisors, just a huge number volunteering with them. They started out by all of their advisors were recruited from those who had submitted kind of complaints through their system. And so what was appealing to recruiting that way for the system was that these are people who cared enough to give constructive feedback to us. They took the time to say, here's how you can do things better. And so that is how they did their initial recruitment, was checking, went to patient relations and said, who do you have we might be able to reach out to and connect with. And so that's a great place if you're looking for diversity. It's connecting with your interpreter services a lot of times is a good place. Volunteer services. A lot of the volunteers in our hospitals are people who have received care in our hospitals, so that's another great place to look. And also organizations that do support for families with special health care needs or things like that, whether it be a cancer support group or children with special health care needs support agency. So community agencies are another really wonderful place. So those are just a few to start people at and think about. Others who are more savvy get into social media and that. But and we'll go into a ton more detail on the next webinar as well.
Thank you so much, Tara. We actually have a chat question for you. This question is from Jill McArdle, and the question is, do you have any advice on the best way to start the bedside reporting practice?
So bedside rounding. So my best advice for that, so for not knowing exactly where you are with it, one of the things I would do, AHRQ, I mentioned their guide to patient and family engagement. They have some really great curriculum that goes through bedside rounding. It goes through teach back and also a smart discharge. So because it's it might surprise some of us that our nurses and providers and ancillary staff that work at the bedside are not always trained or feel confident in doing teach back or rounding at the bedside. So part of it is providing skills to individuals through training, and giving them a safe place to practice it. I know one of the most overwhelming pieces can be, how do I have a difficult conversation at the bedside during rounding, or, whether it's change of shift or bedside rounding. And so the AHRQ resource provides some kind of, here's some suggestions for how to have these conversations, but just being able to practice it can be such a gift. I remember when we switched to bedside rounding and one of the units that I worked in, I think if we had waited for everybody to be on board and ready to do it, it never, ever would have happened. So for us, our unit manager just said, we're going to do it, and this is the start date for it. And so we had provided some, here's how you talk about this, here's how you, suggestions and scripting for talking about different issues. Once we started it, there were no issues whatsoever. So I think it's the fear more than anything. And the other just quick suggestion I would give is, start small. So it doesn't have to be, if you want to do it for your whole unit and there are 60 beds. Don Berwick, who was with CMS and is now back with Institute for Healthcare Improvement, said, whatever your goal is, 60, when you're figuring out, how to try this, cut it in half and then cut it in half again. So that you can test that change of bedside rounding and kind of work out the kinks. And, just try it for a week. Don't say, okay, we got to do this for a month. But, small tests of change can also help when you're implementing these things.
Thank you so much, Tara. That sounds fabulous. I have another question for you. Is there a way, you mentioned during your presentation that you try to make sure that you rotate through and continue the process of recruiting patients, not to wear out any one particular patient or family member. And I was wondering, is there a formal process of evaluation of advisors or faculty that you have involved in your efforts? Do the staff get a chance to give you feedback on the patient and family members who are involved in your quality improvement efforts?
Yeah, that's an awesome question. So what many boards do, so if you're working with a patient and family advisory board, there's oftentimes governance put in place so that advisors only serve, a maximum of two-year terms or something like along those lines. There are different examples, so people kind of do what they feel comfortable with. So that's one way to handle it. Another is, and I want to say Lucille Packard Children's Hospital is one that uses this, and there are others that have kind of a stepwise approach for patient and family members. So at first they're brought in and maybe they serve on an advisory council, so they come to that once a month. And then after they've gained a certain amount of experience, they're put onto a quality improvement committee. And then after they've done that for a while, maybe they become a family faculty member. And after that, maybe they become a committee leader or something like that. So so that way you're not keeping people stagnant within one role, but they have a way to progress to do other things. I love that you asked about a way to evaluate the effectiveness of advisors and that, because so much of the time we talk about, okay, how can we start evaluating the effectiveness of providers based on patient-family feedback. But there was just a question posed in this national listserv that we have through the Institute for Patient and Family Centered Care, asking exactly that question: is anyone doing an assessment of advisors and their effectiveness? And no one has seen one. So that may be something that we need to start working on, actually.
Sounds good. At this time, I'd like to check in with the operator to see if there are any questions on the line, and also to remind people how to ask questions.
As a reminder, to ask a question, press star 1 on your telephone keypad. And we currently do not have any questions in the queue.
Okay. Well, at this time, there are also no additional questions in the chat. Just want to give everyone an opportunity if you do have any questions or comments. At this time, while we're waiting for questions, I would like to thank you, Tara, so much for giving us such an excellent presentation on patient and family engagement. And we are looking forward to the third presentation in this series. We also would like to thank each of the participants for participating in this webinar and invite you to provide feedback about this presentation and the webinar series as a whole. We'll be contacting you after the webinar for your input. We hope that this webinar series and that our webpage will facilitate exchange of information and promote visibility of perinatal quality improvement activities throughout the country. We encourage you to join us for our next webinar in the series on patient and family engagement. You may also visit our webpage. I'm going to put the slide up so you can see it. There it is. Our webpage at www.cdc.gov/reproductive health/maternal infant health/PQC. You may also visit our webpage for additional information about CDC support of perinatal quality improvement collaboratives. And if there are no other questions at this time, we can adjourn this webinar. Thank you again, and have a wonderful afternoon.
Ladies and gentlemen, that does conclude the webinar for today. We thank you for your participation and ask that you please disconnect your line.